السلام عليكم. السلام عليكم. Okay, thank you everyone for joining. Kindly please, if you're aware of any of your colleagues who are still not yet here in the meeting, please try to contact them and let them know that we are starting. Thank you.
السلام عليكم.
عليكم السلام دكتور، أهلا وسهلا، حياك الله.
هلا، كيف حالكم؟ طيبين؟ عمر، دكتور عمر.
حياك الله دكتور، أهلا وسهلا، تفضل دكتور.
الله يحفظك، كيف صحتكم؟ إن شاء الله طيبين؟
الحمد لله بخير دكتور، الله يبارك فيك.
ولا دكتور، الله يحفظك.
الله
عزيزي،
يكرمك.
أحتاج إني أسوي شير سكرين. أنا I
Sure
was
دكتور،
muted, بس you
I'll
need to
give you دكتور the
enable me
host
to.
credential.
Okay.
Sure, noted دكتور. تفضل دكتور, you may try sharing the screen now. We can see your screen clearly, Doctor.
Okay, perfect. Shall we start?
If you don't mind, Doctor, if you can give the students just 1 or 2 minutes, as I've contacted their clinical directors and they will be joining in a bit.
Okay.
Dear students, kindly please remain silent during the lecture. If you have any question, you may raise your hand. And please, if you are aware of any of your colleagues who are not yet here in our call, please contact them to join immediately. Thank you. Okay, Prof, we approached almost the full number. You may start, Doctor.
What's the batch size?
Sorry, Doctor,
Dr. Omar,
your voice was cutting.
what's the size of the batch?
Yes, so Doctor, the number of registered students I have here is 120. So we're almost 30 away. We're almost 91
What?
now.
120 male and female?
Yeah, the total, those that registered, but we're still having candidates registering every day.
Oh, okay. What's the expected batch size سنة كم سنة ثالثة سنة رابعة.
I will check, Doctor. I'll get you the exact number and get back.
احنا متعودين the participants approaching 200 in the last 3 years. So it's almost half the number. But anyway, so you have 120 registered for the course. طيب, السلام عليكم ورحمة الله.
The matter is that we just announced the launching of the course, so the students are still registering. That's why the total number of registries are a little bit low, but they will come up to the full number very soon.
Do you prefer that we delay getting the first lecture until everybody is registered?
I believe, Doctor, since it's an introductory lecture, it's okay, we may proceed, but definitely we'll ensure everyone is registered.
المشكلة في introductory lecture, and I think if you're saving this lecture for the benefit of the students that have not yet registered and are not participating in this meeting, they need to be going over the lecture. They need to be listening to it, because some things are going to be said today and they might be taken lightly or forgotten. بعدين out of historically the last 5 or 6 years, what happens is يجيني طالب at the end of the course, after we grade the papers and after the scores of the exam are out, يجي مثلا 1 or 2 or 3 and they say, well, we didn't know about this, we didn't know about that. Man, a lot of things will be made clear today. It's important. Some of the things I will say today, and I will not necessarily repeat. Some of the things will have to be repeated based on the project. So it's important that everybody has the benefit of listening to this lecture, عشان ما يصير فيه confusion towards the end. Okay?
Okay, Doctor, noted. And I think all the students are listening and they have taken note of that.
And yes, I think you need to record the lecture from this point on, so that whoever was not able to participate today because they have not registered yet, that should be given to them as material. So basically, they would not have missed the introductory lecture.
Sure, Doctor. It's being recorded and we'll share it with them once we are done.
الله يعطيكم العافية. طيب, that being said, let's start. السلام عليكم ورحمة الله جميعا. أنا اسمي ساري رباح. I'm a plastic and reconstructive surgeon by education and training. I currently work في مستشفى الملك عبد الله الجامعي, King Abdullah bin Abdulaziz University Hospital in Princess Noura University. We've been delivering this course. I think this is I'm going to guess 5, maybe the 7th year, 6th or 7th year. I think the 7th year of delivering this course. Okay, for everybody who's in attendance, the concept that this course covers is relatively simple. The contents of the course are also relatively simple. A lot of it is, I'm not going to say common sense, but I'm going to say comes from the real world of practice. Medicine is a super specialized, technically a super specialized field. Like when you come to practice, you're going to be working within environments, within hospitals, within clinics, and things like recruitment of manpower and the procurement of consumables and setting forth strategies and the managing processes will be at hand. So what we try to do is we try to give a bit of introduction to the real world, things to keep an eye on as you finish your education and then your training in medicine, and as you approach full practice and start understanding how ultimately you're going to be part of a system. Okay, I'm going to put you on hold.
Doctor, your mic is muted.
Yes, Dr. Omar, it's intentional. I'm going to put you on hold for a second. I'm going to pick this back up. Just give me a few seconds. Okay, sorry about that. Any questions so far? The course is a very interactive. It's a very interactive course. The concepts that we cover come. Some of the concepts come from the business world, from the managerial world, administrative world. We talk about leadership concepts, and some of you are already born to families or live in such a way where they're really exposed. Others are very are focused within medical school training on the subjects at hand. Like, the material is very ما حقول controversial, like, is open for discussions. But I want sharing. Amar, it's also, Dr. Amar, it's important for the students not to be muted and for them to be able to log on and ask questions when prompted. So we need to also make sure of that. Okay. Moving
Sure,
on.
Dr. Noted.
Thank you. And this is pretty much what I'm talking about. In medicine, and I'm a physician, and I've gone through this. I've gone through medical school, and I've gone through residency, and I've gone through practice, and I've gone from level to level to where I am today. Medicine as a college, after you finish school, secondary school, and you move on to college. As a college, today compared to 7 years ago, the topic is very broad. So what you're given, رؤوس أقلام, you're given as much as we think that medical education is heavy, it's really just the tip of the iceberg in terms of the knowledge in the area. So you're taught the language of medicine so that you can communicate with other healthcare providers appropriately. You're taught some basic clinical skills in terms of assessing patients and their problems, definitely dealing with people in general. You have a chance to overview. It's just like when you're in school, you think about engineering versus medicine versus IT versus finance. When you're in medical college, you also have a chance to overview. Do I want to be an internist? Do I want to be a surgeon? Do I want to be a pathologist, an emergency room physician? If I want to be a surgeon, do I want to be a neurosurgeon or a plastic surgeon? And so on. So you just get an overview in most specialties to help you decide what you want to specialize in. And of course, you learn how to interpret blood or lab results and imaging, and you learn how to prescribe medicines, and you learn some basic procedures in terms of what they offer patients when they're done. And I would say for the last at least 20 or 30 years, research has also become a very important basic skill that's taught at that level. And at the end of that training, you're a generalist physician who has a lot of knowledge, but little ability to deliver that knowledge because that knowledge needs to be taken to a different level in terms of practice. And so you move on to residency. And in residency, things are honed down, things are tweaked. You start learning specific skills in the discipline that you choose. You become very knowledgeable in terms of the pathology and the therapeutics, all within that discipline. You become very exposed. The research now becomes more advanced and more tailored to that discipline. Of course, residency in itself trains you as a physician to deal with high levels of stress, ambiguity, people in their different states, and interpret their cues, not just what they're saying. The product that comes out of that is a specialist, a physician with endurance, perseverance, and confidence, and a physician that is able to practice independently in an independent state. Whether whether your specialty allows you to open a clinic where you're the sole provider, or you join a polyclinic, or you join a hospital and are part of a team. You've just reached the state of autonomy, the ability to. There's an interruption. The ability to practice on your own. But then, as most people will practice, the start is usually as part of a hospital or part of a polyclinic, multi-clinic, and so you're part of a bigger team. You may be, as you enter that team, you may find yourself at a position of leadership from the get-go, because you're the physician and people look to you to make decisions. So here the picture is a little bit bigger, it's a little bit different than what you practice in what you studied in medical school, and then what you trained on in residency. Here it becomes, yes, about delivering patient care, yes, about maintaining quality and safety, but these things are looked at from a measurement perspective in terms of the system. And it's about working within a team, right? And then you have things that you may have not been exposed to, like streamlining care, how to deliver care effectively and efficiently, the patient experience. Not many years ago, patient experience was not the most important. Going to a hospital meant that you're going to be sickly in a ward with nurses and doctors taking care of you. Back in today, the patient experience matters. Today, we look at having patients in a single room so that they don't share space with other patients. We care about not only the quality of medicine that's delivered to them, but also their overall experience, so that their memory of the whole episode is not negative, if not positive, if not negative. And you also start understanding that there's constraints. You can't be as a doctor saying, I need this, and I need this device so that I can perform this surgery, and I need this imaging modality so that I can do this form of imaging. They're costly, and so as part of a system, people who run the system need to look at costs very closely and to make sure that they're able to make resources available. And the same on the human level when we talk about hiring the right people for the right job. And lastly, and not only anymore in the private sector, but also in the government and the semi-government. Right now, healthcare is going through this transition from government to privatization. So market pressures become important because they will determine the revenues of the hospital or the system within which you work, which based on that, the hospital will be able to expand and offer more services and get more resources. And so the market pressures start to matter. All these concepts are not necessarily things that, definitely in my time, we weren't exposed to these concepts in medical school, and I had to wait till after I finished residency to enroll in a master's degree of health administration to be exposed. But I think as a practitioner and somebody who's chaired departments of surgery and had my executive share of executive roles in the past, that it is important almost for every physician to have this basic knowledge, this basic language, this managerial language, and for some physicians to really explore care systems, whether it's a small clinic or the Ministry of Health and ministers. So it is important for these things to to be looked at critically for medical schools and for medical studies today. And these are the challenges, right? These are the challenges in our profession. So the business side and understanding the business side, as I said, is not something that you get exposed to typically in medical school, and working within teams and the concept of leadership and how to lead. Okay, so what is this course? We'll start by answering what this course is not. So this is not a course about business. We're not going to be teaching you accounting 101 or finance 101 or marketing 101. It's none of that. It is a lot of concepts that do have a big background in the business literature as they apply to healthcare administration and to running healthcare systems and hospitals and practice and profession of healthcare today. Definitely, I'm not advertising for you to finish medical school and then join an MBA or an MHA, albeit there's a lot of value in that for some of you who plan on pursuing administrative careers. And I'm not advertising for some of you to follow an administrative career instead of specialization, but we are in this course talking about the importance of understanding the language and understanding the importance of proper leadership for healthcare to persevere and to progress. So it's an overview of the healthcare profession today. Management and administrative terms and concepts will be discussed. Some introduction to some business concepts. Definitely encourage leadership among physicians, because I believe that physicians that understand leadership do it the best. Physicians that understand leadership, not physicians that just lead healthcare. They must have a background or good understanding of leadership in the healthcare sector. And most importantly for me, the course aims to be educational and informative and fun for you guys. We'll see about that part. Okay, I'm gonna stop here for a minute, and so I want to hear any questions from anyone, any queries before we move on. Yes, no, maybe. The group leaders.
You can unmute yourself and speak up, students, please.
I think everything is clear.
Fantastic. I'm going to invite you. You still see my screen? Are you still seeing my screen?
Yes.
No.
Can you hear? Can you hear the presentation? I think you can. Yes, no?
We can't hear it. No, we don't.
You cannot? You don't hear it. You cannot hear it. You just see it. Yes?
Yes.
Yes.
Okay. Well, I'm not sure how to, let me see. I'll try a few things. And if not, I'm going to invite you before we continue to watch this video together. We still can't hear? We still can't
Doctor,
hear?
there should be a drop-down menu at the edge. 3 dots that you press,
Okay.
and then there's an option that says share audio. There should be one.
Share computer sound, yes?
Yeah.
Let's try that. Your default microphone has changed. Can we try now?
It's working.
Can you
Doctor.
hear?
Yes, doctor, we can hear.
Yes, we can.
I got my start in writing and research as a surgical trainee, as someone who was a long ways away from becoming any kind
Hello?
I got my start in writing and research as a surgical trainee, as someone who was a long ways away from becoming any kind of an expert at anything. So the natural question you ask then at that point is, how do I get good at what I'm trying to do? And it became a question of, how do we all get good at what we're trying to do? It's hard enough to learn to get the skills, try to learn all the material you have to absorb at any task you're taking on. I had to think about how I sew and how I cut, but then also how I pick the right person to come to an operating room. And then in the midst of all this came this new context for thinking about what it meant to be good. In the last few years, we realized we're in the deepest crisis of medicine's existence due to something you don't normally think about when you're a doctor concerned with how you do good for people, which is the cost of healthcare. There's not a country in the world that now is not asking whether we can afford what doctors do. The political fight that we've developed has become one around whether it's the government that's the problem, or is it insurance companies that are the problem. And the answer is yes and no. It's deeper than all of that. The cause of our troubles is actually the complexity that science has given us. In order to understand this, I'm going to take you back a couple of generations. I want to take you back to a time when Lewis Thomas was writing in his book, The Youngest Science. Lewis Thomas was a physician writer, one of my favorite writers, and he wrote this book to explain, among other things, what it was like to be a medical intern at the Boston City Hospital in the pre-penicillin year of 1937. It was a time when medicine was cheap and very ineffective. If you were in a hospital, he said, it was going to do you good only because it offered you some warmth, some food, shelter, and maybe the caring attention of a nurse. Doctors and medicine made no difference at all. That didn't seem to prevent the doctors from being frantically busy in their days, as he explained. What they were trying to do was figure out whether you might have one of the diagnoses for which they could do something. And there were a few. You might have a lobar pneumonia, for example, and they could give you an antiserum, an injection of rabid antibodies to the bacterium Streptococcus, if the intern subtyped it correctly. If you had an acute congestive heart failure, they could bleed a pint of blood from you by opening up an arm vein, giving you a crude leaf preparation of digitalis, and then giving you oxygen by tent. If you had early signs of paralysis and you were really good at asking personal questions, you might figure out that this paralysis someone has is from syphilis, in which case you could give this nice concoction of mercury and arsenic, as long as you didn't overdose them and kill them. Beyond these sorts of things, a medical doctor didn't have a lot that they could do. This was when the core structure of medicine was created, what it meant to be good at what we did, and how we wanted to build medicine to be. It was at a time when what was known, you could know. You could hold it all in your head, and you could do it all. If you had a prescription pad, if you had a nurse, if you had a hospital that would give you a place to convalesce, maybe some basic tools, you really could do it all. You set the fracture. You drew the blood, you spun the blood and looked at it under the microscope, you plated the culture, you injected the antiserum. This was a life as a craftsman. As a result, we built it around a culture and set of values that said what you were good at was being daring, at being courageous, at being independent and self-sufficient. Autonomy was our highest value. Go a couple generations forward to where we are, though, and it looks like a completely different world. We have now found treatments for nearly all of the tens of thousands of conditions that a human being can have. We can't cure it all. We can't guarantee that everybody will live a long and healthy life, but we can make it possible for most. But what does it take? Well, we've now discovered 4,000 medical and surgical procedures. We've discovered 6,000 drugs that I'm now licensed to prescribe. And we're trying to deploy this capability town by town to every person alive in our own country, let alone around the world. And we've reached the point where we've realized, as doctors, we can't know it all. We can't do it all by ourselves. There was a study where they looked at how many clinicians it took to take care of you if you came into a hospital as it changed over time. And in the year 1970, it took just over 2 full-time equivalents of clinicians. That is to say, it took basically the nursing time and then just a little bit of time for a doctor who more or less checked in on you once a day. By the end of the 20th century, it had become more than 15 clinicians for the same typical hospital patient. Specialists, physical therapists, the nurses. We're all specialists now, even the primary care physicians. Everyone just has a piece of the care. But holding on to that structure we built around the daring independence, self-sufficiency of each of those people, it's become a disaster. We have trained, hired, and rewarded people to be cowboys. But it's pit crews that we need. Pit crews for patients. There's evidence all around us. 40% of our coronary artery disease patients in our communities receive incomplete or inappropriate care. 60% of our asthma, stroke patients receive incomplete or inappropriate care. 2 million people come into hospitals and pick up an infection they didn't have because someone failed to follow the basic practices of hygiene. Our experience as people who get sick, need help from other people, is that we have amazing clinicians that we can turn to, hardworking, incredibly well-trained, very smart, that we have access to incredible technologies that give us great hope, but little sense that it consistently all comes together for you from start to finish in a successful way. There's another sign that we need pit crews, and that's the unmanageable cost of our care. Now, we in medicine, I think, are baffled by this question of cost. We want to say, this is just the way it is. This is just what medicine requires. When you go from a world where you treated arthritis with aspirin that mostly didn't do the job, to one where if it gets bad enough, we can do a hip replacement, a knee replacement that gives you years, maybe decades, without disability, a dramatic change. Well, is it any surprise that that $40,000 hip replacement, replacing the 10-cent aspirin, is more expensive? It's just the way it is. But I think we're ignoring certain facts that tell us something about the people get more efficient at what they do. And what that means is there's hope. Because to have the best results, we really would be talking about rationing. Who we're going to cut off of Medicare, that would be really our only choice. But when we look at the positive deviants, the ones who are getting the best results at the lowest costs, we find the ones that look most like systems are the most successful. That is to say, they found ways to get all of the different pieces, all of the different components to come together into a whole. Having great components is not enough, and yet we've been obsessed in medicine with components. We want the best drugs, the best technologies, the best specialists, but we don't think too much about how it all comes together. It's a terrible design strategy, actually. There's a famous thought experiment that touches exactly on this. They said, what if you built a car from the very best car parts? Well, it would lead you to put in Porsche brakes, a Ferrari engine, a Volvo body, a BMW chassis, and you put it all together, and what do you get? A very expensive pile of junk that does not go anywhere. And that is what medicine can feel like sometimes. It's not a system. Now, a system, however, when things start to come together, you realize it has certain skills for acting and looking that way. Skill number one is the ability to recognize success and the ability to recognize failure. When you are a specialist, you can't see the end result very well. You have to become really interested in data, unsexy as that sounds. One of my colleagues is a surgeon in Cedar Rapids, Iowa, and he got interested in the question of, well, how many CT scans did they do for their community in Cedar Rapids? He got interested in this because there'd been government reports, newspaper reports, journal articles saying that there'd been too many CT scans done. He didn't see it in his own patients. And so he asked the question, how many did we do? And he wanted to get the data. It took him 3 months. No one had asked this question in his community before. And what he found was that for the 300,000 people in their community, in the previous year, they had done 52,000 CT scans. They had found a problem. Which brings us to skill number 2 a system has. Skill 1, find where your failures are. Skill 2 is devise solutions. I got interested in this when the World Health Organization came to my team asking if we could help with a project to reduce deaths in surgery. The volume of surgery had spread around the world, but the safety of surgery had not. Now, our usual tactics for tackling problems like these are to do more training, give people more specialization, or bring in more technology. Well, in surgery, you couldn't have people who are more specialized, and you couldn't have people who are better trained. And yet we see unconscionable levels of death, disability that could be avoided. And so we looked at what other high-risk industries do. We looked at skyscraper construction, we looked at the aviation world. And we found that they have technology, they have training, and then they have one other thing. They have checklists. I did not expect to be spending a significant part of my time as a Harvard surgeon worrying about checklists. And yet what we found were that these were tools to help make experts better. We got the lead safety engineer for Boeing to help us. Could we design a checklist for surgery, not for the lowest people on the totem pole, but for the folks who were all the way around the chain, the entire team, including the surgeons? And what they taught us was that designing a checklist to help people handle complexity actually involves more difficulty than I had understood. You have to think about things like pause points. You need to identify the moments in a process when you can actually catch a problem before it's a danger and do something about it. You have to identify that this is a before takeoff checklist. And then you need to focus on the killer items. An aviation checklist like this one for a single-engine plane isn't a recipe for how to fly a plane. It's a reminder of the key things that get forgotten or missed if they're not checked. So we did this. We created a 19-item, 2-minute checklist for surgical teams. We had the pause points immediately before anesthesia is given, immediately before the knife hits the skin, immediately before the patient leaves the room. And we had a mix of dumb stuff on there, making sure an antibiotic is given in the right time frame because that cuts the infection rate by half. And then interesting stuff, because you can't make a recipe for something as complicated as surgery. Instead, you can make a recipe for how to have a team that's prepared for the unexpected. And we had items like making sure everyone in the room had introduced themselves by name at the start of the day, because you have half a dozen people or more who are sometimes coming together as a team for the very first time that day that you're coming in. We implemented this checklist in 8 hospitals around the world, deliberately in places from rural Tanzania to the University of Washington in Seattle. We found that after they adopted it, the complication rates fell 35%. It fell in every hospital it went into. The death rates fell 47%. This was bigger than a drug. And that brings us to skill number 3, the ability to implement this, to get colleagues across the entire chain to actually do these things. And it's been slow to spread. This is not yet our norm in surgery, let alone making checklists to go on to childbirth and other areas. There's a deep resistance because using these tools forces us to confront that we're not a system, forces us to behave with a different set of values. Just using a checklist requires you to embrace different values from ones we've had, like humility, discipline, teamwork, This is the opposite of what we were built on: independence, self-sufficiency, autonomy. I met an actual cowboy, by the way. I asked him, what was it like to actually, herd 1,000 cattle across hundreds of miles? How did you do that? And he said, we have the cowboys stationed at distinct places all around. They communicate electronically constantly, and they have protocols and checklists for how they handle everything from bad weather to emergencies or inoculations for the cattle. Even the cowboys are pit crews now. And it seemed like time that we become that way ourselves. Making systems work is the great task of my generation of physicians and scientists. But I would go further and say that making systems work, whether in healthcare, education, climate change, making a pathway out of poverty, is the great task of our generation as a whole. In every field, knowledge has exploded, but it has brought complexity. It has brought specialization. And we've come to a place where we have no choice but to recognize, as individualistic as we want to be, complexity requires group success. We all need to be pit crews now. Thank you.
All right, can you guys hear me? We go back
Yes,
to our, all right, fantastic. So year after year, I've shared this TED Talk with Dr. Atul Gawande. He's a women Brigham's physician in Boston, and just really comes down to the issue of making it all work and working in teams and putting it all together and making the system work. Dr. Omar has probably watched this talk 3 or 4 times along the years. But let's take a 1-minute pause and see if there are any questions or observations around the talk before we wrap up. So I'm opening the floor. Is everybody still here?
Yes,
Yes,
doctor.
doctor.
Okay. So any questions, any observations, I haven't heard from anyone yet, anything that, on what we've said. So that's not how I usually like to conduct the lectures. I'll have to come in person if there's no interaction.
Yes, doctor.
Yes, okay.
Doctor, I would like to ask about the schedule. Is it going to be every Thursday?
Okay, we'll answer that in a bit. What else?
Doctor, so in this specialty, do we work with other majors and other specialities, like let's say a finance major and a business major, or is it only a group of doctors who are specialized in health economics?
Okay, that's a good question. Even though the course continues to be termed health economics, in fact, what we are teaching you is not health economics. So this is not a health economics course. And it's unfortunate that we haven't been able to change the title or the name of the course. This is a health management administration course. That has to be clear. It's not a specialty per se. This is an overview of the managerial and, if you want, administrative aspects of healthcare, with introductions to topics such as strategy, problem solving, innovation, change management, culture, some of these concepts that are in front of you right now, right? healthcare costs and the complexity, quality improvement systems. So that's what the course covers, and it's not a specialty per se. That you'd need to go through a master's to cover course by course, where there's a individual course for health economics, another individual course for accounting, one or two long courses for finance, something that talks about health policy, another that talks about the legality or the legal aspect of medicine and medical legal issues. So that is in terms of having a degree, but this course is an overview. In terms of when, that's not up to me, but I think most it's going to be Thursdays. It can be some Wednesdays if we choose to arrange as such, but most it's going to be Thursdays around this time. There's a co-lecturer, my colleague, Dr. Raed, who lives in the Medina al-Munawwara, and he's going to be either doing it in person or most likely doing it online. He might give you 2 or 3 lectures at a time. So we kind of just like fast forward through the course. And here's what I want you to know. The course is relatively simple. The contents are simple, straightforward. There's some technical aspects that you need to know about, I believe, anyway. Keep it simple. Just don't ignore it completely. I've said over and over for students that participate in this course, it's very easy to get an A in this course, and that is the intention. But it is not impossible to fail, and there has been failures. And so characteristically, a lot of people over the years, a lot of students, around 50-60% get A's, and then another 20-30% get B's and B pluses. But there's always every year 1 or 2 people who unfortunately fail because they just don't get it. They completely fail to attend, they fail to contribute, they fail to follow the work that is given, and there's nothing that we can do for them. The other thing is you have Dr. Omar, who's kind of the go-to person in case you have issues with attendance or any kind of issue, and he will resolve it for you through the college. I, on the other hand, will provide the lectures, and Dr. Raed will provide the work that you need to do. I will be taking care of myself of going over your projects at the end of the term and grading and scoring them. There will be an exam, and the college will be scoring that, and that is the extent of my contribution to the course. Everything that has to do with really administrative issues will have to go through the administration of the college, which does not include me. Okay. So that being said, we used to make a big fuss about attendance because it's a course that has to do with interaction. I really don't anymore. It is upon you to attend or not. Understand though that at the end of every lecture, with the exception of this one, there will be a quiz, and that quiz will be conducted online as you attend the lecture, and will have part of your final grade. In terms of professional conduct and scholastic dishonesty, things pertaining to your overall conduct during the course, I don't think there's anything new or different than what you guys as medical schools already know and follow. There will be projects as part of the course. Some people have attempted in the past to copy the work of others, and some people within a group they don't do the work, and they try to get credit for the work of others. That is not difficult to pick up, and if there's been incidents where it's been picked up, and unfortunately people have gotten zeros on copying the work of others, and it's not difficult for us to do that because I have all the previous projects, and we run them on a program where there's no plagiarism. I talked about accountability in terms of taking credit for what you do. One of the things that happens often at the end of the year is within a group, somebody doesn't do any work, or one person does all the work, and then others try to take credit for it, and they don't get a good grade overall, and they start complaining to me. In terms of your own groups, and when we talk about the projects and how to deliver them and execute them, we'll talk about that. But this is a course about, it is also about the ethics of practice, so accountability is something that will reflect in your final grades. The grading, I believe, and maybe Dr. Omar will correct me, I believe you get 50% for the final exam, and you get 40% for the project, and 10% for attendance in the quizzes. I believe it's somewhere around that. The final grading mechanism will be discussed with you, but it's something around 50% for the projects, 40% for the projects, 50% for the final exam, and 10% for attendance and quizzes.
That's correct, Doctor.
All right. Good. With that being said, if there's no questions, I'll leave it to Dr. Omar and the group leader to arrange for the next talk. The next talk will be about healthcare systems, probably next Thursday. There'll be a quiz at the end of every talk, as we said. And that's it. Thank you very much. Have a good weekend. I'll let all of you go. I'll stay on for 15 to 30 seconds to see if anybody wants to ask any questions. Other than that, have a good weekend. Thank you.
Thank you very much, Doctor. Thank you very much. Dear students, if you have any question, you may ask Dr. Sari, or else we can stay and discuss few technical issues with the class. Any questions?
Yes, Doctor. One last final question, just so I can get the image of the health economics work or like workload. In the hospital, is it under the Department of Quality or is it under the Department of Finance?
Okay. I'll explain it differently. I was in King Fahd Medical City. I myself became a head of the plastics division, and then soon after I became chairman of surgery, and then I moved to another hospital, and I had an executive position. I'm a physician. I'm a surgeon by training, but I studied. I had a master's in health administration, and that tool, if you want, helped me execute my job as a physician leader. My knowledge of business acumen, my knowledge of the lingo of administration, my knowledge in strategy and problem solving helped me execute my job as a physician leader. I was neither under the finance department, and I was neither under the economics department. There's no economics department in a hospital. But certainly when I speak to people in finance, I understand their language. I'm not an accountant, but I understand the principles of accounting so that when they share numbers with me, I understand what they're talking about, ratios like return on investment, return on asset. What does it mean? What's an income statement? What's a balance sheet? What's a cash flow statement? Same goes with other aspects, including IT, including HR, and their practices, recruitment, including procurement. So it was ultimately, for me, it was a tool that helped me in my leadership position. I was surgery. I was in the Department of Surgery, and I was a surgeon who was the chairman of surgery. And when I moved to King Abdullah, I was executive or co-executive of medical affairs, and it was something that helped in leadership. I contributed to many projects in the hospital, like developing policies and procedures, looking at different plans from different aspects. So it's not under a department. You will not find you will find people who have this tool being useful in different ways, just because the knowledge is there. Is that understood?
Yeah,
That is a
Doctor.
yes.
Thank you so much.
Okay. Anything
Any
else?
other question?
When is the first project? Soon. There's one project. Well, actually, there's two projects, but the same topic. You're going to be required to either draft something in strategy or problem solving, and then whether you have a strategy project or a problem solving project, you're going to draft something about innovation in your in the issue that you tackle, whether it's strategic or problem solving. So it's a strategy with an innovation, or problem solving with an innovation, depending on what group you're in. And probably we'll start talking about problem solving in 5 to 6 weeks, and you start working on that. And then maybe 2-3 weeks later, we'll talk about innovation, and you'll start working on the innovation, and you'll have at least 2 to 3 weeks before the exams to submit your final projects. Oh, the other thing, Dr. Omar can overlook this. Yes, I need your whole group after everybody has registered, and very soon to be broken down into groups of 6, males and females separate. We tried to allow mixing in the past, it caused some problems. So between male groups and female groups, groups of 6, not 7, not 5, 6. There might be one group at the end that has lesser students or an additional 7th student. But in general, I'd like to break down the whole number to groups of 6 because we're going to assign to every group of 6 an assignment. So hopefully you can work on that. Where will the quizzes be? Dr. Omar will answer that. They'll be here online. There'll be a code and you'll have to go online and answer. Anything else? All right. With that, we see you all next Thursday. Dr. Omar, thank you very much. And Hiba, I believe also, thank you very much. I'll meet up with both of you. I think Hiba is the group leader that's been communicating with me. So we'll keep it as such. Please don't forget the issue of the groups. If they have any logistical questions to be answered, I'll leave it to you. And thank you. Have a great.
Thank you, Doctor. Thank you very much. We'll take it from here, Doctor. Thank you.
Bye.
Okay, so dear students, please stay in the meeting. We need to discuss a few items. Yes, I just want to confirm that we have the group leader here attending with us. Hiba, are you with us?
Yes, doctor, I'm here.
Yes. Hello, Hiba. How are you?
I'm doing good.
Yes, so just one quick note, please, dear students, if you haven't yet registered in the course, please go ahead and sort out any issues with the student affairs or with any other department, and make sure, please, you are registered in the course. Otherwise, and we want to avoid this problem. It happened last year, and it impacted the final grade of all. Yes.
I have one issue.
Yeah, let me just finish my note, and I'll happily answer your question. I'm really sorry, Sultan, but give me just half a minute. I promise I'll get back to you.
Okay.
So try to sort out any issue with the student affairs. Let me be clear with you. If you have an issue with the student affairs, I can't sort it out. If you have an issue with the finance, if you have an issue with any other department, we can't sort it out. Our authority stops at the limitation of this course. So if you have an issue with any course, you may head to the student affairs department or to Ms. Reem Masoud, as she is our senior student affairs and counselor. So try to sort it out anytime during early next week. Because let me tell you something, the quizzes, and this is actually would be an answer for another question, the quizzes will be posted on Moodle, and they will be answered, corrected, and reported electronically. So I really have no hand in editing, adding, making up any quiz for any student. And we are carefully being monitored by the college. So please put yourself in my place. I really have no authority. If you haven't answered the quiz, that's it. I can't really help you unless you get it's a very complicated process that we make up for anyone. This is number one. Sultan, I'm going to come back to you. Just let me finish these few notes. The class, as scheduled by the college, is Thursday 3 to 5. I totally understand. And look, my job here is to make your life easier. And please help me doing so. I know that we're going to come across weeks where you have finals, where you have some conflicts. I will try in arrangement with the course director and upon the permission of the college to help arranging the schedule in a convenient way, so it don't affect your study plans and the other commitments. But for now, it's Thursday 3 to 5. We tried actually to change it to Wednesday, but it conflicted with so many schedules. Remember, guys, that you are coming from different groups, clinical groups. So what suits you may not necessarily suit the others. Okay, this is number 2. Number 3, I would really appreciate it if I can just have a WhatsApp group. Hiba, maybe you can help me in that. If we can create a WhatsApp group with the group leaders Now, which groups? I'm not talking about the project groups. I'm talking about the groups of the clinical rotations. So we can communicate with each other. So in case on one day we decided to cancel, postpone, or reschedule a lecture, we can just communicate between us, and you guys can help me like distribute or share, spread the word. Now, there is a quiz open model. Yes, there is a quiz open model, but ignore it for this week. The quiz will start on counting starting from next week. So for this week, there is no quiz. Don't worry. It's just an introductory lecture. And believe me, guys, I really assure you that Dr. Sari is unbelievably cooperative. He actually tries his very best to make his life and our life easier. So please, let's help him and let's help ourselves to make this course a joyful and an easy aim. This is actually my goal, and this is the goal of everyone in this college. But help us doing that. Now, let me go back to Sultan's question. Sultan, I'm really sorry. Go ahead and ask your question.
Doctor, I just have one issue. I don't get the email sent by Ms. Hiba regarding the HIN course.
Are you in the hospital?
Yes, I'm registered for the rotations.
It's fine. Can you just simply email Hiba, Ms. Hiba, and inform her that I am not getting the emails related to the HEN 483 course?
I already did, doctor.
Yeah, and it didn't work?
She said you are not enrolled, but I communicated with the IT and the student affairs. They say you are in the list.
Okay, then forward that email to her. And let her know.
I did, but before just few minutes, but I didn't get the response yet.
Communicate with her. If you haven't got it sorted out, let me know so I can find you an alternative.
Okay, thank you so much.
Don't worry that much. You're most welcome, Sultan. But don't worry that much, as we will create a new channel of communication between each other. We're going to sort it out.
Through WhatsApp, doctor, right?
Through WhatsApp, yes. I'm going to be communicating with the leaders, and the leaders will be informing you all.
Okay, thank you so much. Thank you, doctor.
You're most welcome. And I highly appreciate it if we can create the group over this weekend. Just a small group of yourself, myself, and the clinical rotation groups. Now, this is one item. The other item is that you heard Dr. Sari. Let me be honest with you. True, it's an easy course. It's a very joyful course. I really enjoyed it, and you will enjoy it. But don't be misled. Don't be deceived. It's a tricky course. You really need to open your eyes, and believe me, this is gonna be one of the rare moments in your life where you're gonna study something about economics and management or administration. So please take this chance. Soon you will run your own clinics. You'll be the manager or the administrative of your own clinic. So you really need this amount of knowledge. So don't take it as a joke. Please consider this course seriously. Yes, we had last year, the year before, and on every year we had failure rates. We had people scoring an F. Yes, we did. And we had many scoring A's. But yes, we had failures, and failures of people who used to attend sometimes, but did not submit quizzes, never participated in a project. Yeah, so even if you attend, you still may fail. One more item for the groups of the projects, make sure that we have the males alone and the females alone. God knows about the conflicts that we had last year. We don't want to repeat them. We want to make it a smooth course. So please, a group of 6, and Dr. Sari was clear, group of 6, nothing more, nothing less. 6 males, 6 females, and so on. So please arrange yourselves. I'm expecting to hear back. I don't know, would you like to submit, like each group leader to submit the group to one individual of you? Then you can combine them and send them to me. How would you like us to move with things?
Yes, we can do that, doctor. We can ask each batch leader to divide their batch specifically to groups of 6, and then we can compile them in one file and send them to you.
Great, thank you, Hiba. And I'm giving you a word from myself. I will try my very best to make this course a joyful one and a smooth course, but please help me to do so. I can never help myself in that. I need you to help me. And believe me, last year, it was an unbelievable course. It was amazing. They really enjoyed it. It was an easy A for the majority. and they really enjoyed it. And to be honest, let me tell you something, some actually published papers out of this course, which is going to be most likely your only paper in health economics. And God knows, you may become a health economist one day. So let's put it aside one more time. Our class is by default, it's Thursday. Unless we discuss any modification later on, it's okay. We can discuss it. Now and one more thing, Hiba, for you and for the leaders or the representatives, let's try to eliminate as much as we can the communication with Dr. Sari. Let it be only one of us. It's either me or Hiba to communicate with Dr. Sari alone, because Dr. Sari, whenever he gets a lot of messages, he drops them all. Because I don't blame him, because he is getting 1 million messages from different students or candidates. So let's try to minimize and to unify the message. I'll sort it out with Hiba and the leaders. You don't need all to worry about that. But for now, the class is Thursday, 3 to 5. I know that some of you may not prefer virtual, but sometimes the doctor is unable to attend. So he needs on few days to accept it. But we have our classroom reserved, we have our venue reserved, and the timing for us. We will most likely go there starting from next week. The groups for the projects, please from now on, divide yourself and share them with Hiba and the leaders, then they can compile them. So it's on Zoom right next week? No, it's not on Zoom. Next week it will be on campus. But wait, we will look, let's deal with this course as a weekly course. We will confirm it with the leaders and they will deliver the message to you each and every Tuesday, maximum Wednesday. You will get it confirmed. How do we divide ourselves? Okay, that's a tough question. How do you usually divide yourselves, guys, in other courses or in other projects? It's okay. You don't have to have 10 groups of males, 10 groups of females. Like how many males and how many females do we have? Okay, no idea. It's okay. For now, I don't know. You're not all like by default divided into groups.
We have subgroups in hospitals, but they're not necessarily 6 students. Some subgroups have 5, some have 7, some have 8.
Well, the thing is that let's forget about the groups. When it comes to the project, let's forget about the other groupings. We need to have like a new grouping system. I know it's tough, but we have to do it this way. Otherwise, 2 years ago, we had some difficulties arranging the groupings and so on. At the end of the day, Dr. Sari decided to have it randomly done. And believe me, it was a hell.
Doctor, we can just do a Google document, like the BLCs can send them out, and then we'll just fill our names out as groups of 6.
Okay, if you can assure me that this will be ready by the end of Sunday or Monday maximum, go ahead. But I'm afraid this Google Doc will never be completely filled.
No, doctor, it will be filled. That was the method that we followed.
Okay. If you can do it, go ahead. Look, guys, and I'm open to anything, but make sure you have the end goal satisfied. If you can do it, go ahead. Don't even ask me. Go ahead, do it your way. Just at the end of the day, all I care about is to have an Excel sheet with the groups, males alone, females alone, groups of 6, or we may accept one different group just to make the number even. That's it.
Okay, doctor, we'll take care of this, inshallah.
Thank you, Hiba. Any other question? And I know you have 1 million questions, but go ahead. I'll try to answer as much as I can.
Doctor, just to clarify one thing, I'm sorry. So when you said you wanted a WhatsApp group with group leaders, do you mean the BLCs, the batch leaders, or did you mean also to include the subgroup leaders, the hospital subgroup leaders?
I don't know. Now let me just ask a question so I can answer you. Now because your hospital division is different than my old days. We used to be only 2 groups back then. But for your groups, can we have one group that is attending a lecture where the other is not? Or subgroup? Okay, if yes, then I need someone on the WhatsApp group. So whenever I say the lecture is cancelled or postponed, I am assured that the message will be delivered to everyone. And let me just say something. I don't know who came with the idea of writing the name and the ID on the chat.
Hi, doctor. This is Abdullah Zainuddin for Group B surgery.
Hello, Abdullah. Yes.
Hi. We used to do this for the introduction, so I guess everyone picked it up because attendance gets taken like this before.
It's okay, it's fine. But let me tell you something. The attendance is being taken through the Zoom reporting system. That's why it's very important that you log in with your name and ID. But don't worry, today's lecture, the attendance is not a big, I know that some of you are not even yet registered. We will consider that, but we will mark attendance for today. Attendance will never be dropped. But don't panic if you skipped, well, not skipped, if you at least had an issue with your naming on the Zoom. Starting from next lecture, I really need you to, whenever we have an online lecture, make sure your name and your ID just that are there. You don't need to type it on the chat. Now, let me ask a question about the quiz. The quiz most likely will be on Moodle. It will be uploaded on Moodle. I'll give you toward the end of the lecture a code. You will log in and you will get into the lecture. You will answer the quiz. The quiz will never exceed 10 minutes. It's a very easy quiz. Most of the 100% of the answers are being said in the lecture. So if you pay attention, you got the quiz secured in your grade. But make sure that you attend and you solve the quiz, because last year a lot of students were shocked that they saw themselves absent and they came claiming that they attended by answering the quiz, and this was not accepted. So attendance is one, taking the quiz is another. Totally different. So make sure you attend and you take the quiz. Okay? And I'm making up questions and answering them. Do you have any question? Another question I'm making up. You have a lot of questions on the projects. We will discuss the projects 1 million times ahead, but don't worry. If we reach a point where you still feel you are confused, we will give you some samples from previous years, some models, and this will be a very easy thing to implement or to at least to take it as a direction or a guidance. Out of the total grade, yes, attendance and professionalism is 10%. Your final exam is 40. The project is 50. So project is almost half the mark. So yes, you do need to focus on the project. Okay. And let me just open the chat because.
Yeah, Dr. Abdullah Zainuddin, can you give us an overview of what earlier projects were about, or how was it? Yeah, we have no idea what's going on right now.
Look, and I can, Abdullah, give you a lot of, I'll give you a full brief and full overview on the project, but I would love to keep it for Dr. Sari because he likes to introduce it. I don't want to cross the limits. This is his lecture and this is his course, and he likes to be the first one to introduce the project. So, but in brief, the project is divided into 2 phases or 2 parts. However, the second part is an extension of the first part. So if you finish the part 1 of the project, don't think that it's over. And make sure when you do the part 1, you do it very well, because part 2 will be a reflection of part 1. Now, these projects will be divided into 2 major themes, either problem solving or strategy. More than that, I would love, Abdullah, and if you allow me, I would love to keep it to next lecture where Dr. Sari will be talking about the projects more and more. Most of it, the project will be a written document where you all have to participate. And believe me, even if you believe that 1 or 2 candidates are good in one group, they will do the whole work. Believe me, last year, because the material was not easy, a lot of students complained that other members were not contributing to the project, and this created a mess, and everyone was impacted. So from now on, do your share, try your best, don't remain silent, contribute to your group, to contribute to your project, So يعني to maintain the nice culture within your group. Now
Doctor,
we have yes go ahead.
I have a question. The project will be evaluated individually for each part or as a whole group?
Sorry, Sultan, your voice was cutting. I couldn't hear the last part.
Can you hear me now, Doctor?
Yes, now it's clear. Go ahead.
Doctor, the grading for the project will be individually for each member in his part or as the whole group will be evaluated?
لا هو look, it differed. Last year or the year before, we asked like one full paper and each part to be written by one with the name highlighted. The year after, we decided that no, just write it, submit it as a group project. We really don't care who wrote which. I'll leave it up to Dr. Sari. He will decide. Okay?
I think it's more fair to be evaluated individually, right?
I'm not really sure, Sultan, that it will even be an option, because Dr. Sari, if an issue happens, he tries to avoid it by a very firm decision in the year after. So let's wait what is his preference, because I don't think it will be an optional thing. But definitely, he's very open to discussions. We can discuss it with him.
Okay, thank you, Doctor.
Most welcome. What else? Do we have any other questions? No questions? Is it that clear? Okay, طيب. So for today, that's it. Thank you very much for your attendance. I know you weren't expecting the lecture to be virtual, but we had some logistical and technical issues with the arrangement of this course or the class. Next week, I'll be in continuous contact with the group leaders. They will deliver any message, any update to you. And that's it. I wish you a very happy weekend. And remember, it's an easy course. Let's make it an easier one. Okay, thank you.
Thank you so much, Doctor.
Most welcome.